All right. We will go ahead and get started. Thanks again for joining our webinar this afternoon. My name is Sarah Eaglesizer, and I am a nurse with OPEN, the Overdose Prevention Engagement Network. Today's webinar, Bringing Our Patients Comfort, implementation of a new clinical practice guideline for pain management after childbirth. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and click send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME and McBath credits for today's webinar. Unfortunately, we are not able to provide social work credit today. We will have a slide up with information about how to obtain your credits at the end of the webinar. We will also be emailing the continuing education credit information after the webinar today. The Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing the harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who can provide guidance for managing patients who have substance use disorder or complex pain. We offer expert-led education and training sessions, such as the one today. Most of our webinars offer continuing education credits, and for prescribers, all of our credits qualify for the DEA required SUD training. We provide MOUD training for clinicians. Our next training is March 5th from 9 a.m. to 1 p.m. and registration is open on our website. In addition to CME, primary care providers who complete the training will be eligible for a $250 incentive. To prevent new persistent opioid use, OPEN established and continues to update evidence-based prescribing opioid recommendations and counseling recommendations. These are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using the QR codes on the screen or visiting our website. OPEN also provides tangible tools to reduce the harms of substance use and opioid use. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. We provide safe medication storage and disposal options. And we also offer overdose rescue support, including naloxone vending machines and distribution boxes, as well as naloxone administration trainings. OPEN understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. We continue to provide regionally dedicated behavioral health consultants. Each work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally. And with that, I'm excited to introduce our presenter today, Dr. Alex Peel. Dr. Peel is an assistant professor and physician investigator in the Department of Obstetrics and Gynecology at the University of Michigan. Her overarching career goal is to improve the effectiveness, efficiency, and equity of reproductive healthcare, particularly for marginalized groups. She attended medical school at Northwestern University and a residency in obstetrics and gynecology at Brown University. Following residency, she completed the National Clinical Scholars Program, through which she earned a Master's of Science in Healthcare Research and Policy at the University of Michigan. She is a nationalized recognized expert on pain management and opioid use in pregnancy, as well as prenatal care, redesign, and innovation. She is the director of the Partnering for the Future Clinic, which provides prenatal services to birthing people with substance use disorder. She also led the development of the Creating Optimal Pain Management for Tailoring Care, or COMFORT guideline, which provides comprehensive recommendations for patient-centered, equitable pain management after surgery in pregnancy and postpartum. So with that, I will stop sharing, Dr. Peel, and turn things over to you.
Wonderful. Thank you so much for the warm welcome. It's such a pleasure to be with y'all today. All right, perfect. Hopefully everyone's seeing the title screen now. So thank you so much. I am really excited to talk to y'all today about the COMFORT recommendations, which are the hot off the press guidelines coming through the pipeline to improve peripartum pain management. Just a few brief disclosures. I do receive some research support and do some consultation work. But I think the most important thing is that I am a mom. I have a 3-year-old and a baby on the way. And my own experience going through pregnancy and childbirth certainly influences the perspective that I come to this work with. So today we have 3 big goals. First, to identify the risks of opioid prescribing after childbirth and associated procedures. Next, to utilize the evidence base for opioid-sparing pain management. And finally, to be able to describe the new national guideline for peripartum pain management. In order to accomplish these objectives, we'll start with why postpartum pain management matters. We'll go through the COMFORT recommendations, and then to make them a little bit more concrete, we'll go through some patient case examples to show you the guideline in action. So I want to start by actually telling you my story and why I began working on postpartum pain management and opioid risk reduction. In my residency, the night intern wrote all of the postpartum prescriptions. This was often 20 to 30 prescriptions per night, and sometimes those prescriptions were as large as 60 tablets of Percocet. Later on, as a chief, I was covering the floor when a patient came in labor. She had had a prior cesarean, and she was planning to have a trial of labor. And this was especially important to her because she was in recovery from opioid use disorder. Her battle with addiction had begun with her last pregnancy, when she had an unplanned cesarean and went home with 40 tablets of Percocet. The medications initially helped her pain, but more tangibly, they improved her anxiety. And when her script ran out, she got a refill, and when her doctor stopped prescribing, she began buying pills and ultimately heroin on the street. Losing custody of her child was a catalyst for starting her pathway to recovery, which led to the moment that I met her on the labor floor. And as I thought back, I realized that her birth coincided with my intern year, and that I very well could have been the person to write that initial prescription. At the same time, other OBGYNs in our hospital, urogynecologists and gyn-oncologists, were starting to use enhanced recovery after surgery protocols, opioid-sparing protocols with scheduled non-opioids, and limited opioids when needed. And I saw how well people were recovering with these protocols. Even patients after major oncology debulkings were recovering with just ibuprofen and acetaminophen. And I really started to think that we could do better for our patients. At that time, I launched an enhanced recovery after cesarean protocol at my institution, and here at Michigan, I've continued to develop, test, and disseminate opioid-sparing protocols. Now I've come full circle. I'm the director for the Partnering for the Future Clinic, which provides care for birthing people with substance use disorder and opioid use disorder. So the guidelines I will share with you today are designed to make sure that every patient has access to the pain management they need, while also reducing the known risks of opioid medications. So I hope this talk helps you to feel better prepared to provide each of your patients comfort. So we face 2 concurrent crises in the United States. The first is the opioid epidemic. There have been over 600,000 deaths from overdose in the past decades. And we see this escalation reflected in maternity care, with higher rates of maternal opioid use disorder and resulting neonatal opioid withdrawal syndrome. But simultaneously, we face a maternal morbidity and mortality crisis in our country. Birthing people today are more likely to die in pregnancy and the postpartum period than their moms, with over half of these deaths occurring in the postpartum period. In addition, we see huge disparities for groups historically marginalized by race, racism, and socioeconomic status. And we see the intersection of these crises in the number one cause of pregnancy associated mortality in Michigan, overdose related to opioid and substance use disorder. Much of the opioid crisis has been fueled by opioid prescribing and routine healthcare encounters, including childbirth. And in fact, 1 in 75 birthing people who receive an opioid prescription develop new persistent opioid use in the year postpartum. This is for both vaginal and cesarean birth, which suggests that it's the opioid prescription itself, not the painful experience that confers this additional risk. We see wide variation in opioid prescribing rates and prescription size across Michigan birthing hospitals, even when accounting for differences in patient characteristics. And this variation represents an opportunity for improved pain management practices. As you can see in these graphs, the rate of prescribing after vaginal birth ranges from 0 to 53%, half of patients going home with a prescription. And the median prescription sizes are quite variable, from 9 to 150 oral morphine equivalents, or 1.5 to 20 tablets of 5 milligram oxycodones. We see similar variation after cesarean birth, with the prescribing rate by hospital ranging from 31% to 100% of patients receiving a prescription, with a wide range of prescription sizes from 100 to 495 oral morphine equivalents, or 2 to 65 tablets of 5 milligram oxycodone. Just to give you a benchmark, surgical societies recommend 0 to 5 tablets after a breast lumpectomy, or 0 to 10 after open or laparoscopic appendectomies or hysterectomies. This prescribing variation is a huge opportunity for improvement. In addition to this wide variation in practice, the literature documents clear inequities in postpartum pain management that we have to consider as we think about improving care. These inequities emerge for historically marginalized populations, those who are Black, Hispanic, living on low incomes, or facing substance use disorder. And individuals from these groups are less likely to receive pain assessments. They receive less treatment for the same pain scores, and they are more likely to experience disrespectful maternity care, paternalism, and neglect of autonomy. These experiences can further erode trust in the healthcare system and have significant downstream effects for patients and families. As a result, we see conflicting experiences for patients. For some birthing people, our current practices result in too many opioids, as seen in the pink quote. One nurse was like, well, it's in your record that you need to take these medications every 8 hours. Here you go. But I'm not having pain right now. Can't we just switch it out for maybe Tylenol? Without proper guidance and support, these extra tablets received by patients can ultimately develop into new persistent opioid use and even opioid use disorder. At the same time, many patients experience inadequate pain management, as seen in the blue quote. This patient said, I told my provider or clinician I hadn't had any medication in the last 24 hours, and I was literally being ignored. And this is how, especially with Black women, this is how we die after childbirth, because no one is listening. This patient's experience of inadequate pain management and even racism can limit recovery, early parenting experiences, and result in poor mental health. But it's not all doom and gloom. The good news is that clinical practice guidelines can reduce opioid prescribing without compromising pain management. Here you can see data from MSQC, the Michigan Surgical Quality Collaborative, a Blue Cross Blue Shield funded collaborative quality initiative. This group, in collaboration with Open, developed new prescribing guidelines for 9 procedures. The recommendations included preoperative education, opioid-sparing pain management with scheduled acetaminophen and NSAIDs, and limited opioid prescribing within a recommended range. In an interrupted time series analysis, examined opioid prescription size, consumption, and satisfaction. And as you can see in this study of 11,000 patients, there was an 80% decrease in opioid prescribing with equivalent pain scores and satisfaction. This suggests that maternity care professionals can also reduce opioid prescribing while maintaining excellent pain outcomes. But we have work to do. And part of that is the need for effective, comprehensive clinical practice guidelines. Fortunately, precedent does exist within the maternity care space for opioid-sparing pain management components. Current recommendations from major societies, including the American College of OBGYNs, Enhanced Recovery Society, and the Society for Obstetric Anesthesia Providers, include education, use of scheduled non-opioid medication, and limited prescribing, all hallmarks of an opioid-sparing protocol. But these guidelines aren't sufficient. They do not provide specific information on different procedures, for example, vaginal versus cesarean birth, and associated complications like third and fourth degree laceration or other childbirth procedures. Additionally, guidelines don't include specific recommendations for populations like individuals with complex pain, such as opioid use disorder or chronic pain. Finally, current guidelines lack specificity on medications, such as the appropriate number of opioid tablets to prescribe, which limits their effectiveness. So, given these gaps in current postpartum pain management and the need to promote better pain management and a more equitable, patient-centered experience, the FDA sponsored a UL1 grant to develop new guidelines for postpartum pain management across populations and procedures. And the first step of this grant is the development of the COMFORT Clinical Practice Guideline, creating optimal pain management for tailoring care. To develop the COMFORT Guideline, we completed 3 phases of work, which you see here on this slide. In step 1, we completed a systematic review and gathered existing evidence. In step 2, we held a consensus panel with national experts and used their recommendation in conjunction with the data to develop guidelines. And finally, in step 3, we brought in the lived expertise of patients and providers, allowing us to incorporate their perspectives into recommendations and making sure that the ultimate guideline was responsive to the needs of patients and the people caring for them. And at every stage, we included patient and community engagement. For the consensus panel, we used the RAND UCLA appropriateness method, which is an evidence-based consensus method for guideline development. We had 17 national experts from across the country that considered scenarios with specific populations, procedures, and interventions. You can see an example of a scenario here where the population is patients who cannot receive NSAIDs or acetaminophen. The procedure is cesarean birth with a patient being discharged on postoperative day 2, and the intervention is opioid prescription size. And these 3 components then turn into the scenario you see below, asking about the appropriateness of different prescription sizes for this specific patient and procedure. Multiple specialties were represented in the consensus panel, as you can see here, including maternity care organizations, anesthesia and pain medicine, surgery, addiction medicine, nursing, and others. And we also included 3 individuals with lived expertise, including a patient with a history of opioid use disorder, to round out the experiences contributing to these scenarios. And so with this background, I'll review the COMFORT recommendations in more detail. There are 6 key categories of pain management interventions in the COMFORT guideline. And you can see the more detailed recommendations within each of them here. And so we'll take each of these one by one. The first recommendation is that patients should receive robust education and counseling about pain management, opioid prescribing, and risk reduction. Recommendation 2, scheduled non-opioid medications with acetaminophen and NSAIDs should be used first line. 3, non-pharmacologic strategies should be offered to augment pain management. 4, inpatient strategies may be considered, especially for patients with more complex postpartum pain. 5, after optimizing non-opioid strategies, patients and clinicians may consider tailored opioid prescriptions through shared decision-making. And then finally, The panel concluded that maternity care professionals should use a principles-based approach to postpartum pain management for patients with opioid use disorder, chronic pain, and other complex pain. Before we dive into the clinical recommendations, I just wanted to share these overarching recommendations focused on patient centeredness and health equity determined by the panel. These principles are really designed to overcome significant inequities in current maternity care delivery. And these include standardizing pain management offerings to promote equitable care, but also within these recommendations, tailoring care. In other words, the panel recommended standardizing the options that patients would receive. The second recommendation is to encourage clinicians to engage in self-reflection and education on the influence of bias and social stigma. And then finally, encouraging clinicians to build collaborative alliances with patients through compassionate care responsive to patients' lived experiences, preferences, and values. Okay, so recommendation 1, education and counseling. I think for many maternity care professionals, this is second nature when we're thinking about intrapartum pain management. Does the patient want an epidural or nitrous oxide? Who will be around to support them in labor? This recommendation extends that counseling to postpartum pain management, ideally pushing it into the antenatal space to be discussed before the birth hospitalization. The panel concluded that all patients should be counseled about the expected recovery following any possible mode of delivery, vaginal or cesarean, and also address how trauma, mental health, and opioid medications can influence that recovery trajectory. And second, every patient should be informed of when and how to contact their team for pain. For patients receiving an opioid prescription, they should receive additional counseling, much of which is covered in the Michigan Start Talking form, but this includes the risks of opioid use disorder and overdose, and the increased risks of those items when mixing opioids with other medications. The panel concluded that naloxone should be discussed and offered for any patient receiving an opioid prescription, and that counseling should also include safe storage and disposal of opioids and the safety of the medication with lactation. The next category is the scheduled non-opioid medications, and that all patients should receive scheduled non-opioids with acetaminophen and NSAIDs as first line for postpartum pain. For some of you, this is very familiar if you've already implemented enhanced recovery or opioid-sparing protocols, but for some, this may be brand new. This recommendation is the crux of both reducing baseline pain and reducing opioid prescribing. And implementation of protocols with this component have reduced inequities in prescribing and pain scores. So this is both an important intervention for improved quality of care as well as health equity. The evidence for this recommendation is clear for using scheduled non-opioids after cesarean birth. The evidence is less strong following vaginal birth, largely because it has not been studied. But we know that average pain scores following vaginal birth in the week postpartum without an opioid-sparing protocol, are a 4, which is treatable by national standards. Further, these regimens are recommended by national societies after both major and minor procedures. And so for these reasons, the panel recommended scheduled acetaminophen and NSAIDs after both vaginal and cesarean birth. Here you can see 2 sample schedules. And there is growing evidence that the simultaneous schedule, administering both acetaminophen and ibuprofen, may be more effective than the staggered schedule of alternating medications. And the simultaneous schedule requiring medication only once every 8 hours may also just be more pragmatic, limiting the burden for inpatient teams as well as parents when they are discharged. I just want to share that the schedules represented here are based on an every 8-hour dosing, which has been more effective for implementation here at the University of Michigan. And I hear from my patients it's a little bit simpler to implement than the 6-hour dosing. But dosing medications every 6 hours may also be appropriate. And if that is within your practice, then that is an acceptable approach as well. It is just important to ensure that individuals are remaining within the daily thresholds of these medications. For those of you who have perhaps not used an opioid sparing protocol before, I just wanted to share some quotes from frontline nurses on their experiences. We know that sometimes this can seem like a big logistic barrier, particularly after vaginal birth, where we are not routinely providing these kinds of scheduled medications. So, from one nurse, I was skeptical of the protocol when it first started, but I'm a convert. I think it works well, and we're doing a service to our patients. With the orders being standardized, we're staying on top of it better and not getting behind. And so we're not needing to go to other things like oxycodone. And from a nurse manager, we set this as an expectation, and the whole team really embraced it. Across all disciplines, this is a message that's reiterated successfully, and we present this as the way we manage pain. So as you can see, though this may be a tough transition, people working at the bedside see the firsthand benefits. The third recommendation is about non-pharmacologic options, and that these options should be offered to augment pain management following vaginal and cesarean birth. All patients should receive a menu of non-pharmacologic strategies as an adjunct to their pain. And for pain after vaginal and cesarean birth in particular, heat, ice, and abdominal binders should be routinely offered. Other strategies like mindfulness, music therapy, aromatherapy may be appropriate, but have uncertain benefits. Here you can see an example of a potential comfort menu for patients. This can be customized to the resources that your hospital has to offer. And I just want to emphasize that it's important to introduce these options as supportive. In our interviews, both patients and providers reflected how introducing these strategies can go wrong. For example, if a patient thinks the only thing that they'll receive for their pain is lavender oil, that might erode the patient-provider trust. But these strategies can be really effective as a part of a comprehensive protocol and have the added benefit of helping with stress and anxiety, which can further contribute to or exacerbate pain. The fourth recommendation is about inpatient strategies. And the strength of recommendation and evidence really varied for each mode of delivery here. Specifically, the panel recommended that following cesarean birth, long-acting regional analgesia in the operating room is appropriate and considered standard of care. For patients who have more complex postpartum pain or don't receive standard treatments, for example, someone who requires general anesthesia instead of spinal or epidural with long-acting morphine, PCAs, tap blocks, ketamine, and surgical site infiltration have uncertain benefit. For vaginal birth, surgical site infiltration with local anesthetic has uncertain benefit, and similar to many of the interventions for cesarean birth, it is unclear if this is an effective strategy that should be utilized. However, the panel agreed that the other interventions, tap block, ketamine infusion, PCA, and perioperative gabapentin would be considered inappropriate. The fifth recommendation is about tailored opioid prescribing. That this should only be utilized after non-opioid strategies have been optimized and should be explored through shared decision-making. Specifically, the panel recommended using prescribing benchmarks for individual populations and procedures to determine the appropriate opioid prescription ranges to offer in the shared decision-making context. And I'll show you those benchmarks in just a moment. The panel agreed that shared decision-making should take into account the timing of discharge and inpatient opioid utilization and pain scores, but that clinicians should really be aware of and try and safeguard against biases and inequities that can affect this decision-making process, including current pain assessment practices and how pain scores may further codify existing biases, perceptions of how a patient's anticipated level of activity influences pain, how providers may perceive a patient's risk of opioid misuse, and finally, patients' ability to share their preferences within the power structure known in our medical systems. The panel did provide specific recommendations on which medications should be offered if an opioid is needed. Specifically, morphine, hydromorphone, and oxycodone were considered appropriate regardless of plans to breastfeed when prescribed in standard doses. In other words, less than or equal to 30 milligrams of oxycodone or the equivalent daily. Due to the potential for ultra-rapid metabolism, codeine and tramadol are not considered first-line medications and are also seen as less effective. Due to concerns about acetaminophen overdose, products that are combined with an acetaminophen opioid are not preferred. I also want to share that as we've shared these guidelines across the state, we've heard concerns that oxycodone is more addictive than a combined opioid acetaminophen product. And this misconception is really the vestige of drug scheduling published by the DEA. Prior to 2018, combined products were labeled as Schedule 3. However, with emerging data of their high addictive potential, they were also reclassified to be Schedule 2. And so because of the other risks inherent in these combined medications, oxycodone is preferred over the combined. Here you can see the table of prescribing benchmarks that were developed through expert consensus, informed by data where feasible. Across the top, you see the different procedures that are potentially performed as part of childbirth, including routine vaginal and cesarean birth, but also births complicated by third and fourth degree lacerations, hysterectomy, or uterine artery embolization, for example. And then below, you see the recommended opioid prescription size, deemed appropriate by the panel in terms of 5 milligram tablets of oxycodone. And you can see here that for many procedures, no opioid prescription was deemed appropriate. This list is not meant to be exhaustive, but rather to give examples of procedures that folks can use as an anchor. And so if a patient experiences a deep sulcal lack that the clinician feels is similar to the extent of a third or fourth degree, they may consider that 0 to 5 tablets of oxycodone is appropriate for that patient. Care of individuals with opioid use disorder and chronic pain can be quite complex and really requires a nuanced, supportive approach. The panel affirmed that comfort can still be the foundation for patients with opioid use disorder, and that the opioid-sparing principles and patient-centeredness can be incredibly important, particularly for these populations. But they also provided additional guiding principles for caring for these patients, including general care considerations, recommendations for managing pain in individuals on long-term opioid therapy, and specific additions to the comfort principles, such as utilizing Toradol for an extended period of time. Interviews also highlighted the significant stigma faced by birthing people with opioid use disorder, their difficulties with pain control, and their poor care experiences. I think this quote represents it best. So I think with being an addict, a lot of times hospitals think you're drug seeking when you're telling them you're in pain and you need something. For example, during my pregnancy, my epidural came out and they didn't believe me. Then finally, after hours of checking, they realized it had. I felt like I was being treated like I wasn't being taken seriously, and that they just thought I was trying to get drugs, even though I'd been clean ever since my pregnancy. If you have questions about caring for birthing people with opioid use disorder and their pain management principles, please do not hesitate to reach out. This could be a lecture in and of itself, and we are always happy to help. And I just want to reemphasize that comfort can still be the care foundation for this population, and that these additional principles can help to ensure optimal management. In addition to the wonderful resources outlined by Sarah at the beginning of this presentation through Open, if you have specific questions about birthing people with opioid and substance use disorder, please do not hesitate to reach out. We are able to receive patient referrals for this group at our Partnering for the Future clinic here at Michigan Medicine, and the contact information is here. Or you're welcome to just reach out to me directly, and I can help to coordinate your questions or care for your patients. All right, so now I just want to share with you a few of the implementation tools that we have developed to help support comfort. These tools have been developed in collaboration between Open and the Obstetrics Initiative, which is a Blue Cross Blue Shield funded collaborative quality initiative. This QR code will get you to our website with all of our comfort tools. There are great background materials that outline the initiative, provide you with a protocol that can be used at your institution, and also include both patient and provider-facing resources to help you to get this protocol off the ground. All right. So now that we've talked about the different components of the comfort guideline, let's put it into action. And throughout these examples, I'll share considerations for a patient centered approach to pain management, which you'll see in pink boxes. These suggestions came from our interviews with patients and providers and can really help to improve health equity and the patient experience of postpartum care while ultimately delivering that high quality of care experience. So, the first case study that we'll go through is Maya. Maya's preparing for the birth of her first child. She had an uncomplicated pregnancy and she's planning a vaginal birth. And she sits down for a conversation with her provider at a routine prenatal visit. During her appointment, her clinician initiates a conversation about pain management, including what to expect during and after a vaginal or cesarean birth, medication options, and the safety of those medications. She also remembers that Maya was really worried about pain management after she goes home, and so she includes a discussion of postpartum pain management as part of the foundation of their discussion. Maya is also able to ask some specific questions, like how long she'll feel pain and how medication affects breastfeeding. And this conversation reflects a patient-centered approach asked for by our patients and providers. It includes comprehensive clinician-initiated conversations about pain management, not waiting for the patient to bring up their concerns. And also the chance for the patient to ask questions and elicit concerns about pain management. Maya receives an epidural in labor and she has a vaginal birth with a third-degree laceration. She receives scheduled non-opioid medications around the clock using the combined schedule. She uses non-pharmacologic strategies, including ice on her perineum and a heating pad for cramping. And she requires only one dose of opioid medication the first time she walks the hallways. She felt prepared for this outcome, is really grateful that she knew her options prior to her birth hospitalization. As the team prepares for discharge, they gather information to inform her pain plan. These include her individual risk factors for pain. She does not have any birth trauma or mental health diagnoses that might influence her pain management. Her preferences include minimizing opioid medications. She's concerned about constipation and her ability to care for her baby. Throughout her hospitalization, her pain scores have been less than 4. She's only required one dose of opioid medications in the past 24 hours, and she's going home 2 days after birth. The team considers 3 components of her pain management plan: non-opioid medications, non-pharmacologic strategies, and opioid medications as needed. Maya and her clinical team discuss that many patients don't need any opioids for pain management, and they discuss how around-the-clock, over-the-counter medications can continue to reduce her overall pain. They also discuss the benefits of the different schedules, and ultimately, she selects the simultaneous schedule, which has been working well for her in the inpatient setting and seems like it will fit better with newborn care. Her team also brings up potential barriers to taking the medications, and Maya shares that it might be difficult for her to afford her medications. So instead of asking her to buy the over-the-counter medications on her own, they send a prescription to her pharmacy. They also discuss how non-pharmacologic options can help to reduce pain. Maya's familiar with this comfort menu because she used it during her hospitalization, and she shares that heat and ice have been really helpful. She's also interested in trying out mindfulness to help with pain and also the stress of being a new mom. The team discusses how comfort measures supplement her pain plan, and they make sure not to minimize her pain as part of the discussion. And they also discuss low-cost options for mindfulness, including a handout and a free app that won't require any extra out-of-pocket costs for her. After deciding on these opioid-sparing strategies, Maya's provider checks the appropriate opioid prescription size based on her birth procedures. As you can see, she had a vaginal birth with a 3rd or 4th degree laceration, in her case, a 3rd. And so 0 to 5 tablets of 5 milligram oxycodone would be considered an appropriate prescription size. The clinical team discusses that fewer tablets might be appropriate for patients who needed fewer doses in the hospital of opioids who had good pain control, and for those who have higher concerns about opioid risks. Maya and her team together select 0 tablets. She really feels a sense of autonomy in being part of the discussion and being able to actively participate in this decision-making process. So to summarize, Maya's pain is well controlled. She does not receive additional opioid medications. She's able to use the mindfulness techniques she learned during her postpartum hospitalization and sees that these can be really helpful for managing postpartum anxiety that she experiences in the first few weeks at home with her newborn. She also is more aware of her mental health and is able to seek referral to a counselor for more strategies. Overall, she feels a positive birth experience and has a newfound trust in the healthcare system. We'll go through just one final example, and this patient is Jamie. Jamie is preparing for her third cesarean birth. Her pregnancy has otherwise been uncomplicated to date, and she knows that her family is complete, so she plans a postpartum salpingectomy. She, like Maya, sits down with her provider during a routine prenatal appointment to talk about pain management after birth. Her provider brings up the conversation about pain management after the cesarean and shares with her some specific options, similar to what Maya's provider did. Jamie's really concerned about how this cesarean birth might be different from her prior, and also how she can take care of herself, her children, and her new baby while recovering. To bring in that patient-centered approach, Jamie's doctor invites her partner to be part of the conversation so that both Jamie and her husband can be included in the discussion. Jamie has a scheduled repeat cesarean birth with a salpingectomy. Unfortunately, there's a fair amount of scar tissue during her surgery, and she also has significant uterine atony with a postpartum hemorrhage. She receives long-acting regional analgesia and scheduled non-opioid medications following her birth. She uses an abdominal binder and a heating pad to help with discomfort, and she regularly requires opioid medications for pain scores that are 6, 7, and 8 every 6 hours. She is really glad that she was prepared for the potential for increased scar tissue and a more complex birth. And she is ready to get home to her kids. Jamie's risk factors include birth trauma, the hemorrhage, the blood that was hung, and the urgency of the care team in the room at the time of her cesarean have left her with some symptoms of post-traumatic stress. Her preference is to get home to care for her children. For the most part, in the 24 hours prior to discharge, her pain scores have been at a 4 to 6, and she's required 4 doses of opioid medications in the past 24 hours. Her team helps her to form her pain management plan in the same 3 categories as we discussed before: non-opioid medications, non-pharmacologic strategies, and then opioid medications as needed. Jamie's pain has been difficult to control, and she has found that the staggered schedule is actually more helpful for her, receiving pain management options with acetaminophen and ibuprofen every 4 hours. She is really worried, though, about being able to continue this schedule when someone doesn't bring it in and remind her once she gets home. And so she and her team discuss setting alarms and timing meds with infant feedings. For her non-pharmacologic strategies, Jamie has had a lot of help with the abdominal binder, as well as heat, in particular for some back discomfort that she's experiencing after being in the bed for a little bit longer than usual. She also is interested in trying deep breathing to give her a moment of peace with her 3 children at home. And she's really worried, though, about fitting this into her usual routine. So her team discusses how she can do deep breathing during infant care, such as washing bottles, to really help her have a moment of grounding. After deciding on these opioid-sparing strategies, her provider checks the appropriate prescription size based on her procedures. And for a cesarean birth, going home on post-op day 2, 0 to 15 tablets is the appropriate range. They sit down and discuss where her opioid prescription should be based on her risk factors and her pain experience. Because she's required more doses of opioid medications in the hospital and has had higher pain scores, they discuss that she may want to be closer to 15 tablets than to 0, and together they select 12 tablets. They discuss that if her pain is not well managed at home or she requires an additional prescription, that she can call triage anytime to discuss next steps. And she feels much better and more confident about going home with this knowledge of 24/7 access to relief. So, in short, at the time of discharge, Jamie's pain is better managed and she feels prepared to go home and take care of herself and her kids. She learned a lot of new techniques in the hospital, including the staggered medication and how the abdominal binder and even deep breathing can help. Though she had some initial symptoms of post-traumatic stress, she does not develop postpartum PTSD, and overall reflects positively on her birth experience and the way her team helped her to feel seen and heard. As you can see from Jamie and Maya's example, patient-centered pain management that reduces opioid medication utilization is possible. I hope the information today has been helpful, and I know that together we can improve postpartum pain management, the patient experience, and health equity overall. Thank you so much for joining today and for your time, and I very much look forward to your questions.
Thanks, Alex. We had one question entered during your presentation, but please feel free to enter questions into the Q&A. Okay, you should be seeing the CME slide now as well. First question we have, thank you so much for your leadership and research to advance this important issue. Also, thank you for saying birthing people throughout your presentation. What does the research say about health disparities for queer, lesbian, bisexual, and trans and gender diverse birthing people related to pain management disparities and opioid use and overdose?
Yeah, thank you so much for this question and for highlighting the importance of language in this space. I do think it's a place that many of us are working on being as inclusive as possible. And I trained in a time where we only talked about pregnant women. And so I always appreciate when folks point out other areas that I can be more inclusive and more thoughtful in the way that we're speaking about our patients served. Most of the data on opioid prescribing and opioid use in the postpartum period comes from national claims data sources. And often those national claims do not have the most robust markers of the kinds of populations that you're talking about. So for the subgroups, patients who are queer, lesbian, transgender sometimes is coded and we can get some information there, but largely this is difficult to assess. And so in our systematic review, we did not find any studies that looked at pain management practices within these populations. One of my colleagues here at the University of Michigan is developing a new cohort of trans individuals to follow across the pregnancy to postpartum experience. And I think that will be an incredible opportunity to understand some of those questions. And certainly we are in need of better data sets that identify these characteristics that can allow us to answer those important questions.
Thank you. I had one question for you. When we were going through the prescribing recommendations, and there's, the table of the, various procedures and the prescribing recs. So if a patient has, let's say, a cesarean birth, and then they have, some sort of complication and need a wound vac, or they end up needing a peripartum hysterectomy, are the pill counts in addition to, or do you prescribe additional pills based on having, let's say they had a cesarean birth and a hysterectomy? Would you prescribe 30 pills, or would you still prescribe the amount that was in one of those boxes?
Yeah, it's a great question, and the panel had a lot of discussion about this. I first want to start by saying that the recommendations are not a replacement for clinical judgment. And so these are meant to be prescribing benchmarks or a place to say for your very typical cesarean going home on post-op day 2, here is a range to utilize. And we want people to try and use that as the starting point because we know having this standardization can help to reduce inequities. And we don't want to have the unintended consequence of a patient going home with insufficient pain management.
Mhm.
We actually went back and had the panel rate the hysterectomy independently of other considerations. So we had started off by talking about the hysterectomy being combined with one birth type or another, and found that that was a little bit difficult for folks to consider, particularly in the cesarean realm, where this may be a planned scheduled cesarean hysterectomy. And so that is the recommendation that that pill count is based off of. So for a scheduled plan hysterectomy, the panel felt that the laparotomy itself was really the main driver of pain, and that the hysterectomy component would not really drive a difference in pain management. And this pill prescribing limit matches
Mhm.
Michigan Open's recommendation for open hysterectomy as well. So there is no difference in the peripartum period. Um, some of you may be thinking, but a peripartum hysterectomy is more morbid than a scheduled routine hysterectomy. And that is true. Patients can have significant blood loss with peripartum hysterectomies. There may be more complications and additional procedures needed, like stenting. The panel discussed that in most cases, that complexity would be outweighed by the amount of time that the patient would spend in the hospital. So often folks will be admitted for a bit longer, which in turn reduces that necessity of the postpartum opioid prescription size. But in short, I think clinical nuance is certainly important in coming into these conversations. And it is one of the challenges, I think, in anything with medicine. Engineering, we know what the part will do, we know what the parameters are, but our patients are human with all of their individual nuance and the resulting complexity of procedures and postpartum courses.
I think you mentioned a good point about the 24, like what's um how how has the patient's pain been controlled within, how many of our hours? I think it seems like 24 has been kind of used previously, but how the patient's pain has been controlled before. And so if we've seen scenarios in other collaboratives where they've really tried to implement some measures and prescribing recommendations, kind of using that as a benchmark as well. Because, like you said, if you've had a patient who's been in the hospital for longer, even though the prescribing rec might say, 0 to, whatever, 15 pills or 0 to 20, depending on how long they've been there, and how their pain has been controlled over the last 24 hours before discharge, they may or may not, need additional or less medication. Um, One more question. How does pain medication affect baby?
So when we're thinking about the scheduled non-opioid medications, acetaminophen and NSAIDs, these medications are generally considered safe in pregnancy and lactating individuals. And so part of the comfort recommendation is to actually discuss that with birthing people. We heard a lot of concerns in our qualitative work about the effects of these over-the-counter medications. And in fact, in the co-branded handout that's available for patients, there's a specific call out that goes through the safety of these medications and can help patients to have that right top or right front and center as they're thinking about their pain management plan. In the prescribing ranges recommended by the comfort panel, opioid medications are also safe for patients who are lactating. That is, again, 30 milligrams of oxycodone daily or the equivalent with either hydromorphone or with morphine. There is concern with the utilization of codeine and tramadol, and there's actually an FDA warning against using those medications in people who are lactating because of the risk of ultra rapid metabolism and infant sedation. Any patient who is lactating and planning on taking an opioid medication should receive information on monitoring the infant for signs of sedation. And ideally, timing those medications after feeding can help to reduce those risks. But overall, these medications are safe, and patients who are lactating should not be denied effective pain management after birth.
Let's see. Where's the question, or excuse me, where's the patient handout again for the over-the-counter medications? We can put that, you're referring to the brochure, right, Alex?
Correct, which should
Okay.
be linked on the main Comfort website, which I can provide. And I'm also happy for the slides to be shared in PDF form as well.
Okay. And so I have it right here as well, the link to the brochure.
Perfect. Thank you.
Mm-hmm. Okay, so that's the link. I just put the link to the brochure in the chat, and that has the information in it for patients. Okay, any other last minute questions for Dr. Peel before we wrap up today? Great. Well, thank you so much again. We will be using this course and creating some continuing education material. So stay tuned, everyone, for that. Feel free to share when it's available. We will let everyone know, but otherwise have a great rest of your day. And thanks again for joining us. And thank you so much, Dr. Peel, for presenting. Appreciate it.
Thank you for having me.
Okay, bye. Take care.